Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome back to part 2 with Dr. Julie Hershberg, who is a founder of Reactive Physical Therapy and Wellness and Reactive Education, where she's known for treating the whole person with equal parts clinical skill and compassion. In this episode, she dives deeper into the crossover between functional neurological disorder, also known as FND, and concussion, sharing how to spot subtle patient cues, connecting the dots others may miss, and use creative, evidence-based tools to help even the most complex cases move forward. Welcome to the Concussion Corner Podcast. My name is Dr. Jessica Schwartz. I'm a physical therapist, brain injury survivor, and founder of Concussion Corner, and I'm so happy that you're here. Let's begin. Welcome back to Concussion Corner, Dr. Hershberg.
I'm so glad to keep going in our conversation.
I know we left people leaning in, so I want to just keep going. We'll have episode 1 also in the show notes as well. So if people didn't catch up on episode 1, they can do that after they finish this episode. But let's get right back into it. We've been talking about FND, functional neurological disorder. We'll be talking a little bit about concussion as well. And then some of your upbringing as a neuro-PT superstar in our world from an educational standpoint and a treatment standpoint, and also as a business mentor and leader in this field as well. Let's get into what do FND patients look like from let's talk about subjective standpoint. What are they saying? What are their words that maybe clinicians may be missing in their conversations with their patients? Because oftentimes with concussion and FND and other neurological disorders or neurodivergent happenings, the subjectives are missed. And it's like, it's so clear if you're working with this patient population, it's like, boom, okay, I've got it. But if you're novice to the clinic and you're having that very Dunning-Kruger or cognitive blind spot because you're not aware, what are some things that you're hearing subjectively that patients have said to other providers and have been mismanaged? And this, again, is always a place to build people up, never tear down. But I think it's so salient for folks to know, you know what, like maybe I had a patient 3 years ago that said that. And I'd love to hear some of the subjectives that you're hearing pretty commonly that either seem very nuanced or being just completely missed out and outside of your walls.
Yeah. That's a really brilliant question. I think one of the biggest pieces that I'm listening for is that person's kind of timeline of their experience. And oftentimes what we hear is some variability, right? So they had some symptoms, then it went away, then it got a lot worse, then it went away, it started in the neck, moved to somewhere else in their body. And it started with a slight tremor. And then maybe it changed to dystonia. Like those are two of the most common presentations from a movement, like functional movement disorder standpoint. Or both of my legs went suddenly weak. So that kind of sudden onset, and then it went away. Or, and here, like I'm giving you so many things because it's so heterogeneous, right? There's not two people that present the same way. But that variability in the time course is such a big clue. Now, what I would say I listen for even more closely is like when that person says, my leg suddenly went weak, then I might start asking or listening for autonomic symptoms, right? So I think one of the things that I think people miss in FND is that there can also be other things going on or other things contributing. And so not when the person has that diagnosis of FND, but now they also have dizziness and headache, like they might also have vestibular migraine, right? And so I am probing for those really common, we talked last time about clusters, comorbid conditions that might be contributing to the development or maintaining their FND. And I think those are the things that get missed more. It's autonomic and sensory components, probably the biggest, but even physical injuries are missed because the healthcare team maybe ignored it because the person had like really extreme other neurologic symptoms. So I think that as a clinician is really important to get the whole picture.
Yeah. And I think also the same thing with the concussion conversation, right? It's like in absence of understanding that there are clinical profiles now and that we can do targeted comprehensive targeted physical examinations on these folks. I think in absence of evidence, again, I've said it in the first part, is we either elude people are malingering or it's all in their head. And again, it's brain injury. So hello, FND is happening in the brain. It's the software component of the hardware, right? And it's the same thing with concussion. So just thinking, with the concussion world, right? We kind of alluded for decades that people were malingering and faking it. And unfortunately, the neuropsychological, like the PhD research and the legalese got after the language of concussion. And then just alluded that everyone was faking it and just didn't want to make payouts for car crashes or intimate partner violence or any other insurance payouts from a third party perspective. Now we have comprehensive targeted physical exams for concussion, and we can actually identify the clinical profiles and rehabilitate these folks. And it's amazing. And we see them 6 weeks out and 5 years out and 10 years out if they were a service member. And we can still make impacts on these people's lives functionally. In terms of FND, very similar conversations, especially with the autonomics, especially with our ocular motor for our concussion folks. And again, those are so high level ways of thinking. And for me, for example, gosh, in the early mid 2000s, when I was going through PT school, my concussion education was a paragraph in a 1,500 page neurological textbook. Okay. And it was a small paragraph. It wasn't even like a big one. So in terms of the FND conversation, we're talking about autonomics. We're talking about the same with concussion. What are you seeing in terms of objective tools that you're able to utilize in the clinic that people may have not heard of?
Yeah. Well, and it's interesting, like the concussion clinical profiles and the clinical tools, I think have grown so much. And I actually think my work in concussion has really informed my work in FND, that we can use some of the same pieces there and discover some of the same, like there's overlap heavily in these profiles. And so we use this pie chart framework to look at, are there sensory components, autonomic, lifestyle, physical impairments, motor control impairments, psychosocial components as well, and kind of make a concussion clinical profile for somebody with FND. It's an FND profile. We need to publish this, I think. But anyway, yes. So for example, in the autonomic nervous system, just like we would do with somebody post-concussion, we're going to do an active stand test. We're going to look at heart rate variability and heart rate in general, but we're going to screen for things like POTS and other forms of dysautonomia. And here's the thing, like we're going to treat that too. And in fact, it might not look much different than what we can bring to a person post-concussion. So we're going to do a really low and slow, graded exercise or activity. Now I'm going to make it a lot more fun than doing bridges for sure. And make it externally focused because that's just one piece autonomic. We're going to assess the motor control component and look at what happens when somebody is just walking versus walking with an external focus or goal orientation. And then I'm going to bring that into my autonomic training as well. So most people with FND with a motor control component are going to perform better with a goal orientation to their movement. So they're going to move better towards a target than they are just to say lift their arm. And we're going to bring that right into training and have it overlap with things. One other test that I'm obsessed with that our OTs brought to the team is the sensory profile. So I'm obsessed with this because I love it for myself. It's why I realize I have to move so much while I'm standing here and talking. Because that's part of my sensory profile, but it really informs us, what does this person need from a sensory standpoint? And how can we build nervous system regulation from that? So that's one of my favorite sensory assessments and tools. And the toolbox keeps growing, I think, for all of us, which is hallelujah. We can bring some objective testing to measure these things and get in there and really help a person improve in those areas too.
What are some common, barriers that you may find with either third-party payers or employers, or even across the aisle, other clinicians that you're working with bidirectionally for your patient, with the patient in mind? What are some barriers that you've faced in your career when working with these FND folks?
Well, you were talking about the healthcare system. I will say, with in mind that we can do positive clinical testing, we could get objective measures. I've never had somebody's care denied outside of just general, we only cover 20 visits or things like that. So that I think is a good thing. We can show progress, we can track things, like people get better, like that is great. However, in some areas of the medical system, the healthcare system, once somebody has FND on their chart, I've heard several people now get denied like an inpatient rehabilitation stay, even though they are completely paralyzed. We've seen people here at Reactive outpatient rehab who were denied inpatient stays, and these were people that couldn't eat, couldn't see, couldn't speak, were fully paralyzed except for their neck muscles. Like very, very appropriate for inpatient rehab, but because of that diagnosis, and honestly, from the poor understanding of that diagnosis, were denied care or only offered to go to a psych ward for treatment. Very inappropriate for the person who is fully paralyzed. It clearly has a motor control issue. Now, I feel very lucky in my bubble of Los Angeles. It's very FND aware, not everywhere, but like the major medical systems here, very, very aware, very understanding of the most modern definition of FND. But I see people from all over the world, and that is not the case. And they're denied care, and they're denied physical therapy for physical symptoms, which is just ludicrous.
And you have the good fortune to be able to, be a professor at USC. So you're really seeing that new entry-level doctor of physical therapy come out. I mean, in terms of language like motor retraining and external focus and sensory recalibration and sensory, interoceptive training, which we just talked about with Ann Duke from a pelvic PT standpoint. And this physiological support, are we talking about that in entry level now? And I know USC is one of the top PT programs in the country, and let's call a spade. Are those conversations happening, from an entry level standpoint? I know that's not going to probably be on the boards, but what are you seeing from an entry level standpoint?
Well, I mean, again, thank you. We have this in our entry level curriculum, and like teach it. So I kind of said, hey, we need this. I actually had to present it to our faculty and say, give all the evidence why we needed it. We introduced it in our classes in the third year as differential diagnosis and assessment and treatment. So I did that about 5 years ago. And just this past year, got it approved in our neuropathology curriculum, in our neuro treatment curriculum. So it comes 3 times. I recorded it for our hybrid pathway as well. So, and I'm hearing from other people teaching all over the world that they're getting bits and pieces in there. And personally, for ours, we're actually doing the whole pie chart, right? So we're getting the motor control pieces, those sensory pieces, autonomic, screening for comorbid conditions comes up. So I might be most proud of that than maybe any of the things that I have done, because that's over 100 students a year, 100 DPT students that get to leave school having some knowledge and background in this. And it gets me excited for the patients they're going to come into.
Fantastic. At NYU, Kevin Weaver is the orthopedic director of the residency over there at NYU. And if you've met Kevin, he looks like a biker. He looks like he should be riding a Harley Davidson, but he's the nicest guy. And I remember we had a lecture from Tara Jo Banal on the lumbar spine and the knee from Tara Jo. And she was at Delaware and she works for APTA now. And she won Professor of the Year twice through all of the awards, for APTA and such. And I remember leaving residency and be like, wow, I want to be like her one day. And I got to see Tara actually in Boston. And I said, Tara, she's like, Jess, how you doing? And it was the same thing. And I let her know, because we keep these things inside until we see people. But I hope that the 100 people that you touch every year, I hope they feel the same about you. And I know we're going to put this out onto the internet. It's going to be seen by tens of thousands, if not hundreds of thousands of people. But I hope the folks at USC feel that from you too, because not only are you delivering with such passion and such clarity, but also just they can see it and feel it, that you're doing it in the clinic and you're doing it so well, really serving people. Because again, so much of our healthcare system is designed and it unfortunately burns out people. And that's a real conversation to have. And sometimes we need to take breaks. I just take a break for a year. not because I'm independently wealthy, because I really needed it. But I'm back and I'm back here to deliver. And I hope that those young folks who are maybe burnt out by finals and then they come back and learn from you will take that out to wherever they work in all 50 states or if they go international to serve. So just thank you for doing what you're doing. Really just that Meryl Streep applause for you here in New York. I just love amplifying people who are doing great things.
It's Jazz.
All right, now that we've made Julie blush a little bit, we're going to talk about concussion and FND crossover, okay? So there's this subset of patients that develop functional neurological symptoms post-concussion, okay? And especially if symptoms persist beyond that 2 to 6 week recovery window. We just had Steve Brulio on the podcast, and he's our president of the Concussion Sport Group. He's doing one of the primary research portals for the CARE Consortium with the NCAA and Department of Defense. He's also the dean at University of Michigan and all that jazz. He published that 2003 article, NCAA article, that said concussion recovers in 7 to 10 days. We now know the scientific method is real, and we re-question all the things. And my big thing is you guys do all of this wonderful research and teaching. I dumb it down to we have to know what we're looking at, so we know what we're looking for. And we've had 20 plus years of information on concussion and increased data and biomarkers and blood and fMRIs and all that jazz. And so they've debunked their own research, and 50% of folks will get better in 14 days at the NCAA DOD, like high, top 1% of athletes in the world. And then we're looking about 28 days on average. People are getting back 28 to 30 days from a sports perspective. And that's someone who has excellent care, an athletic trainer, a physical therapist, physician team. They're being monitored daily, sequentially, days 1 through 7. That's not typical civilian. They're not going through no-fault car insurance, having to deal with third-party payers or people believing them or having to take care of children. Because again, these are young athletes. With that being, and servicemen and women. With that being said, what are you seeing for the patients that are coming into reactive PT that have concussion? They either had a misdiagnosis of FND or they're coming in with both a concussion diagnosis and FND, or none of the above. And maybe you're picking it up and you're treating a high ankle sprain and you're picking up that they fell, skiing in Whistler over the weekend and they're a little off on Tuesday. What's that crossover that you're seeing, and what are the important salient things that people should be looking for, with this crossover?
Yeah, we do see a lot of crossover, but I would say we might be an unusual clinic, right? Because it's like we have a well-established program for people with persistent symptoms as well as acute symptoms post-concussion. And we have an FND program. And so we're just kind of known to treat the most complex cases. So we see a lot of folks that might have both of them. And in fact, one of the first people that ever did our intensive program is Molly Parker, who developed a functional movement disorder. She's a physical therapist. So people in the concussion world I know have heard of her usually. She's a physical therapist. She's brilliant. She developed a functional movement disorder after experiencing a concussion. And the literature has caught up to us a little bit here to say this isn't entirely unusual, but it's not the same thing. So that's important. Like persistent symptoms don't equal functional neurologic disorder. But you can develop both. And whether it's in like Molly Parker's case, where she actually developed a movement disorder on top of it, or if it's that somebody has developed a tremor or weakness, sometimes it could be in the form of developing 3PD. And after that's a real common one because of the vestibular components of that. So what we see clinically is two things, Jess. We see the person that has been diagnosed with both in like positive signs of both things, and we can treat the whole picture because there's so much overlap with all of the systems: autonomic, visual, sensory, motor, so much overlap. But we also see people with FND. And again, I get to be that person a lot of the times. That's the first meeting and I'm getting this history. And I'll just say, have you ever had a concussion? Oh yeah, actually it was like 2 months before my FND occurred. Okay. And nobody linked that for them. And it, to me, it's like, well, no, that you might develop FND after a concussion because of the similar brain network changes that occur in both. So that's the other group, is that we're seeing the connection. And then does it change what we're doing? No, because we're treating the whole person regardless of, we have people that developed FND after an ankle injury, after a traumatic car accident, people that have developed it after being diagnosed with multiple sclerosis. The exact mechanism doesn't always mean we have to do something different, but it's really helpful to understand. And I think from our patient's perspective, putting together those pieces to go, oh, this might have been the piece of the puzzle that kind of set off a cascade of brain changes for you. That's really helpful to know when you're living with something that's not well understood.
Fantastic. In terms of, I could spend all day with you, but I know you have a patient in a few minutes and this is going to be our closing question, but how do altered sensory and autonomic processing show up in your patients with persistent post-concussion symptoms and FND? What does that look like for someone that doesn't work with this patient population?
Yeah, my favorite topic. So, let's start with the sensory system. So lots of pieces where we can see overlap between these two diagnoses. I think the biggest is the integration between visual and vestibular information, particularly when it comes to the otolith. Now, I always joke because I really love to stimulate my otolith, which is why you see me swaying here a lot. But most of my patients are actually not so happy about stimulating their otoliths because there is an integration dysfunction happening. So something might be tuned up too high, something too low. And so while the otolith really is a sensory vestibular organ, it has such intimate connections to the autonomic nervous system that this is a really big area where we'll first hear those subjective symptoms of I feel disconnected from my body. I feel really overwhelmed when I move through the world, or I get up from a chair, or maybe there's the component of a visual motion hypersensitivity. And then we know to kind of ask some of those otolith and autonomic questions, but that leads us right into treatment too. So I just gave you kind of where that sensory and autonomic really overlap. But I love it because it is one of the under assessed or treated components, and it can give somebody some pretty immediate relief, whether they have FND or persistent post-concussion symptoms.
Amazing. We're going to have you on 16 more times. You have no choice
Please.
About it. So, okay. Literally, we can talk for days. But for folks that really want to learn from Dr. Hershberg, her Instagram is absolutely fantastic. I think, are you on TikTok as well?
We are
now. Okay.
It's
yeah.
really
so
hard for me. I got to say,
to put all the Yes, no, I know, but the Instagram is so good. So if you go to her Instagram, we'll put all those links in the show notes. There are such high yield examples of what this looks like. And again, I hope you get lost on there. And this is not a doom scroll. This will be such an educational thing for clinicians from PT, OT, speech physicians, and so on and so forth, to really get an idea of what this looks like in terms of, this is not just a straight leg raise. We want to understand the mechanics behind it, the person's emotions, their position, the space in which they're involved, how we're speaking to the patients, their internal, external focus, and so on. And there's so much more we can unpack, but I know you have to treat that patient. So Dr. Hershberg, where can folks find you on social media? And also, let's let them know about where they can learn from you as well.
Yeah. So Instagram is best. So reactivept.com. It's literally me on there. So if you send me a message, that's me responding to you. And then as clinicians, reactiveeducation.com is where we have all of our free resources and courses and things like that. And reactivept.com is where, if you're a patient, you should find us. And in fact, we have great free resources. We have this great new headache concussion resource that we created with our team that we just put out. So you can find that reactivept.com/concussion. FND, like any of our programs, we have some great dystonia resources there for patients too. You can send patients that way for a lot of free resources and learning. We're really passionate about that.
Fantastic. Well, listen, Julie, thank you so much for coming on the Concussion Corner podcast. Your patients in Southern California are so lucky to have you, and your FND support group as well, that is in your group for all over the world, is also so lucky to have you. Again, the best thing we can do is validate those patient symptom profiles. And I know that you're seeing your patients 360 inside and out, and they're so supported and so lucky to have you. So thank you so much for what you do. We hope to see you soon on another episode, because I'll have you on here another 20 times.
Every day, Jess. So thank you so very much.
Take care. Today, we explored how functional neurological disorder and persistent post-concussion symptoms overlap. From subjective red flags clinicians often miss to objective tools like autonomic testing, sensory profiling, and motor control assessments that can change the course of a patient's recovery. Dr. Hershberg shared how these approaches can be integrated into care, why understanding the patient's full story matters, and how sensory and autonomic regulation can unlock function for people living with complex neurological conditions. You can learn more from Dr. Hershberg and her team by visiting reactivept.com for patient care and reactiveeducation.com for free resources, courses, and clinician training. Shares high-yield education and real-world case insights daily on her Instagram, so connect directly with her at ReactivePT on Instagram. For concussion education, visit us at concussioncorner.org and join our flagship courses like Concussion: The Patient Rehabilitation Journey Part 1 and 2, and stay connected with the Concussion Corner Podcast by subscribing on YouTube, Spotify, and Apple Podcasts. It means the world when you subscribe and leave a review. It helps us grow so much, and together you can be a part of our Teach One, Serve Many community. We're so happy that you're here. Take care.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.